I'm Uwe Konerding and I come from the University of Bamberg and was concerned with a user survey which was performed in the project of managed outcomes. The central research questions of managed outcomes were to be investigated in the 6 study countries England, Finland, Germany, Greece, the Netherlands and Spain, and with respect to 4 different diseases. These diseases were diabetes, stroke, hip osteoarthritis and dementia. For each of these 4 diseases, a survey was performed. These 4 surveys addressed relevant information from the perspective of the healthcare users. In the case of diabetes, stroke and hip osteoarthritis, the patients themselves were taken as healthcare users, and in the case of dementia, the patient's proxies. The survey was based upon a conceptual frame which was more or less derived from the theoretical frame which was the basis of the whole project. According to this frame, the focus of the investigation lies on the relation between the features of healthcare and outcomes on the side of the patient. The features of healthcare investigated were mainly access and output. The outcomes were in the case of stroke, diabetes and hip osteoarthritis, patient's health. In the case of dementia, the burden of the proxy and the hospitalization of the patient. In addition to that, also variables were investigated which could be assumed to moderate the relation between features of healthcare and outcomes. In the cases of diabetes, stroke and hip osteoarthritis, these variables were patient's behavior, and in the case of dementia, patient's health and proxy's situation. In addition to these variables, also the evaluations, the healthcare users' evaluations of the features of healthcare and the outcomes were investigated. Originally, the survey was intended to be performed in 6 study countries for all 4 diseases. In other words, it was intended to be performed in 24 case instances. In 2 case instances, this failed. One of these case instances was hip osteoarthritis in Germany. The reason for the failure was that there were no providers who wanted to cooperate with the project. In England, for hip osteoarthritis, there were providers who wanted to cooperate, but they didn't want to have a survey performed by the project. Instead, they only made available data from a survey they had performed on their own. Altogether, a lot of questionnaires had been returned in the survey. The numbers of questionnaires returned range from 7 for dementia in the Netherlands to 475 for diabetes in England. Unfortunately, not all of the questionnaires returned could be included into the analysis. One requirement for being included in the analysis was that the persons who had completed the surveys had sufficient language competence. For stroke, hip osteoarthritis and dementia, an additional requirement was that the participants were, or more precisely the patients, were treated at the right institution at the right time. So several of the questionnaires had to be excluded. In the brackets within the table, you see the numbers of questionnaires included. They range from 4 for dementia in the Netherlands to 387 for diabetes in the Netherlands. Considering the objectives of the total project, the most important questions to be answered by the survey data are whether the different case instances within the same case differ with respect to the outcome variables after standardizing the case instances with respect to those variables which do not reflect features of the healthcare but which can nevertheless be assumed to have an effect on the outcome variables. For diabetes, the standardization variables were gender, age, and education of the patient, diabetes status of the parents of the patient, time since diagnosis, and demand segment. After standardization for these variables, there are statistically significant differences between the case instances with respect to health state. The patients in the Dutch case instances are clearly most healthy, but the patients of the Finnish case instances are not far behind. Definitely, the patients with the worst health are those patients from the English case instance. For stroke, The standardization variables are gender, age, and education, just like in the case of diabetes, but in contrast to the case of diabetes, the further standardization variables are health directly after stroke, previous stroke, and time since stroke. After standardization with respect to these variables, there are statistically significant differences between the case instances with respect to health state. Again, the patients of the Dutch case instances are clearly most healthy, and they are followed by the Finnish and the English patients. The patients which have the worst health are the patients from the Spanish case instance. For hip osteoarthritis, the standardization variables are gender, age, previous hip operation, health state directly before operation, and time since operation. After standardizing with respect to these variables, there are no statistically significant differences between the case instances with respect to health states. That means the operations performed in the different countries all seem to have had the same effect, more or less. But there's still some further remarkable results in the data. One of these results is that the patients in the Netherlands are operated at a less severe health state than the patients in the other countries. Further, it seems to be that in Greece there's a very good treatment of pain in the time between the decision for the operation and the performance of this operation. For dementia, the standardization variables are patient age, patient confusion, the personal relation between patient and caregiver, and caregiver health. After standardizing for these variables, there are statistically significant differences between the case instances, both with respect to caregiver burden and to the expectation of sending the patient permanently into a care home. However, the pattern of these differences is different for both variables. In Spain and Greek, the caregivers experience a very strong burden, but in spite of this, they are very reluctant to send the patient into a care home. They are by far more reluctant to do this than in the other countries. This might be due to cultural differences between the southern and the northern countries. This might, however, also be due to a different supply of care homes in the southern countries in comparison to the northern countries. Thank you.